Good afternoon, and welcome to the virtual town hall for December 4th. Thank you for joining us today. This afternoon, our agenda will include updates on our operations and COVID-19 census, vaccines, guidelines to maintain a safe learning environment, and wellness. We will have time for Q&A, so please submit your questions to the chat box. First, I'd like to share some news about a leadership position. Yesterday, the Board of Regents approved the appointment of David Miller as the new UMHS president, effective January 1st, 2021. In this role, David will oversee the strategic direction and operations of our health system and ensure alignment of our research and education missions. As you may know, David is currently the Chief Clinical Officer for UHCVC and has served in a number of other leadership roles since he joined the Urology Department in 2008. We are all extremely excited to welcome David to his new role and look forward to working with him in this new capacity. I would also like to take a moment to thank and recognize David Spollinger, President of the health system for the past 4 years. With Dave's guidance, the health system was restructured to its current triad model of leadership, and we've made many strides in our quality and safety initiatives. Dave's influence has been far-reaching in his 26 years of service here, with pivotal leadership positions in the primary care program, the faculty group practice, and ambulatory care. Dave will be transitioning back to clinical practice in the Department of Internal Medicine at the end of the year. We thank him for his dedication, committed service, and all that he's done for Michigan medicine, and wish him all the best in the future. I also want to share with you that Michigan Medicine is participating in a nationwide campaign to slow the spread of COVID-19. In a coalition with 119 other hospitals, we're showing solidarity and alignment on a united message to mask up. Ads will be running in major newspapers like the New York Times and the Wall Street Journal. We are also partnering with other local health systems to place ads in our own communities. And I can't emphasize how important it is to be vigilant and intentional when it comes to masking, social distancing, and hand hygiene. As you'll hear today, our COVID-19 cases have been rising, and we need to do everything that we can to keep our workplace and our communities safe. As we enter the holiday season, I know people are thinking about how they can give back to our community and those in need. And I'd encourage you to consider how best to support our community and our Michigan medicine community. Development has set up a website, giving.medicine.umich.edu, to learn about various ways to provide assistance if you wish to. And we will send this link out in future updates. If you want to donate or ask how to do so, please use this site. It's a great resource. Now I'll turn it over to Dave Spollinger.
I'm going to provide just a little bit of an update of COVID activity around the state. As Marshall mentioned, we hit a peak in this past week of 112 patients in the hospital. That has come down a little bit. And if you look at the activity around the state, you can see that beginning in mid-March, we started having an exponential rise in the number of cases around the state. Though the last 2 weeks, though at a very high level, we have seen some flattening, and we hope this continues, though we don't know what the impact of Thanksgiving will be. Next slide. Likewise, hospitalizations have gone up across the state, and you can see in Region 2 South, which is our region, there's been a 22% growth over last week. Now that's down from the previous week, but it's still a high growth rate. But other parts of the state that have been hit hard are now seeing declines in cases, both in the western part of the state, northern part of the state, southwest. But in 2 North and 2 South, we continue to see some rises going forward. Next slide. Fortunately, we've seen a flattening and even decline. Yesterday, there was just under 800 case ICU patients across the state. And as you can see, even our Region 2 South, we've had a 4% decline. in adult ICU use. The importance of this information is that this will be important for you to understand as David Miller and Nancy May talk about our operational plan going forward and how we've incorporated this information and projections of activity across the state in that plan. Next slide. You can also see that for the most part, 40% of our new patient admissions are coming from Washtenaw County, and that's been fairly stable over the last 10 days. And then most of the ICU, most of the transfers have been for ICU and ECMO care. And that's important to understand as we put together our operational plan as to where our patients are coming from and how they're being transferred. So finally, I'm going to turn it over to David Miller, who's going to spend some time talking along with Nancy May about our operational plan to balance both COVID and non-COVID care in University Hospital. Thank you.
Thank you, Dave. Good afternoon. Nancy May and I are going to spend the next several minutes discussing an update on our continued efforts to balance care for patients with COVID-19 and care for patients with other conditions. And this is an ongoing daily process. And I want to start with just expressing gratitude for all of our teams, our clinical teams across the organization as we respond to daily changes and continue to try to achieve this balance. Can I have the next slide, please? So I've shared this slide in previous presentations, but it's important to come back to it. I think every time we talk about our operational plans, because there are many challenging decisions that we have to make, and putting those decisions and the plans against the principles is very important. And again, our emphasis on patient and employee safety, the ability to maintain access for COVID patients, including surge capacity for rising number of cases, while at the same time maintaining access for patients with other conditions, achieving a continued commitment to citizens of the state, and then thinking about how our operational plans can reduce the impact on our teams to the greatest extent possible. And these are all principles that we hope will be reflected in the plans we'll present this afternoon. Can I have the next slide, please? This is also a slide that we've shown many times in the past, and I would draw your attention to the top right portion of the slide where we talk about rising number of patients in the ICU, and we have presented the concept that if we reach an ICU census of 30 or more patients with COVID, that we would consider opening the RICU. And we're close to that now. As I'll show on the next slide, I think we were at 29 patients as of this morning. And so the understandable and important question that many colleagues are asking is, when will we or are we opening the RICU? And what Nancy and I will present today is that we do not have any immediate plans to open the RICU. While we're continuing to regularly consider this option, we are instead looking at alternatives to RICU activation, and we will try to discuss that in some detail and the rationale for that approach. Can I have the next slide, please? So as I mentioned, if you look at our census this morning, we're at 29 patients in the ICU and 97 adult patients in the adult hospital. So again, the question is being asked is, are we considering RICU activation, and if so, when? Could I have the next slide, please? Well, the operational plan that we'll discuss this afternoon reflects both the significant implications of RICU activation, as well as some data that I'll share related to the natural history of hospitalizations for patients with COVID, as well as some of the details Dr. Spollinger shared related to the epidemiology of the pandemic statewide. But what about the RICU? After all, in the spring, the RICU was the first step we took in the management of the pandemic. Well, we did learn some significant lessons from activation of the RICU. And the first is, when you consider this decision in the context of our principles, what we know is that activation of the RICU would have a very significant impact on non-COVID care. Opening this 32-bed unit in children and women's would displace pediatric patients and result in a 10-bed loss for children and women's during a very busy season for pediatric hospitalizations. It would reduce beds for patients requiring bone marrow transplantations, who are often uniquely who often receive services that are uniquely available here at Michigan Medicine. It would result in the movement of patients back to University Hospital, and a 22-bed loss for University Hospital. That's now exacerbated by some reductions in capacity we've seen through changes in our partnerships in the local region. The net result would be a dramatic reduction in access to care for patients without COVID. Again, thinking of our principles of balancing COVID and non-COVID care. At the same time, opening the RICU would require major staffing changes to accommodate adult patients. This staffing of the RICU would require transfer of teams from other units, likely ICUs, including the cardiovascular ICU, the neurosurgical ICU as two potential examples. These changes in staffing would require further reductions in UHCVC beds due to staffing shortages, and could potentially impact ambulatory activity through requirements of our colleagues in the ambulatory setting supporting staffing requirements in the RICU and in other inpatient locations. So again, when we think about the impact of our operational plans on our teams, this is a major consideration. Can I have the next slide, please? So if we're not going to open the RICU, what is the alternative? And what we're going to talk about in the next several slides is a concept of a micro adjustment approach. Small but frequent adjustments in our operational plans that allow us to achieve our principles, to keep our patients and teams safe, to mitigate the impact of these changes on our team, all the while balancing care for patients with COVID and patients without COVID, and maintaining our commitment to citizens of the state. And while we refer to this as a micro adjustment approach, we recognize fully that each of these changes has major impact for our teams. And the resilience and commitment of our teams in implementing the changes we'll talk about in the next several slides has been remarkable, and we are deeply grateful for the commitment. Could I have the next slide, please? So what have we done to date to implement these micro adjustments? Well, for the last several months, we've been focused on expanding ICU capacity in University Hospital, particularly in 8D, where we're now able to staff up to 18 beds. We've created more capacity for moderate care on 6C and 5A. We've increased our staffing for inpatient medical services as our medical census now routinely exceeds average levels. And we are working daily on close clinical and operational coordination across many units where patients are moving from intensive care to moderate care to general care, coordinated with our transfers and with the clinical services taking care of the patients and unit leadership. We've developed a consistent transfer process that we've discussed in prior town halls, and we've established a teleconsultation service to support the management of patients who are not transferred to Michigan Medicine. And we've already reduced our scheduled OR activity in UHCVC, meaning that some patients in need of surgery or procedures have already had their care delayed. Can we have the next slide, please? So the question is, can we continue this micro adjustment approach now as we contemplate the question about the RICU? And there are a couple key pieces of data that I'll share in the next two slides that we think support this approach. The first is that we've learned a lot about changes in the natural history of hospitalizations for patients with COVID during this resurgence compared to the spring. And there are a couple key points. First, overall levels of ICU utilization have been lower for patients who've not been transferred to Michigan Medicine. So 20% ICU utilization versus 35% in the spring. In addition, we know that patients transferred from other hospitals comprise approximately 50% of our current ICU census. So if you think about the need for ICU stays, this has been driven in many ways by transfers, and there have been lower use for patients who've been admitted through our emergency department or clinics. In addition, and very importantly, an observation by our clinical teams has been that fewer patients who are receiving treatment with heated high flow nasal cannula are progressing to mechanical ventilation and therefore requiring longer stays in the ICU. And this has been at 30% in the past month versus 48% over the prior 6 months. Putting all this together then, our observation and our conclusion has been that moderate care beds rather than ICU beds are a key resource constraint that allow us to use the ICU capacity we've created over the last several months. And Nancy will talk about all of these issues in a bit more detail as we discuss next steps. I have the next slide. This is my last slide, and this was actually shared by Dr. Spollinger. And the point from this slide is to say, well, we've made these observations about the natural history of hospitalizations for patients we're taking care of in the last 6 weeks, but the decision about this micro adjustment approach during the RICU also has to be informed by what's happening at a state level. And as we're showing again in this slide, an important observation has been the relative stabilization of ICU utilization across the state. If this number was rising rapidly, we would have to be thinking more quickly about potential increases in ICU capacity. But we think putting these data together, that this micro adjustment approach may continue to serve us well as we try to adhere with our principles. So now I'll transition to Nancy May, who will talk about our next steps with this micro adjustment approach, what it means for our clinical operations, for our teams, and how we can continue to support our teams across the organization. Thank you again.
Thank you, David. There's been a great deal of work, and these micro adjustments have been fascinating to watch, because what it does is really gives us a great picture of the potential we have to continue to move forward and not open the RICU, as well as optimize every bed and ensure that we have the right bed for the right patient at the right time. As we looked at what the projection of the patients were, as David had said, we realized that moderate care was really needed. And about 2.5 weeks ago, we started to take a look at increasing the footprint of moderate care by opening 10 additional beds on 7C. Today, we have 5 of those beds being fully utilized, and by Monday, we'll have an additional 5. Doing these micro adjustments is really giving us the ability to keep from opening the RICU. Every bed that we can gain in the UH and CVC footprint gives us hope that we will continue to keep our teams together. We also know that if our ICU capacity jumps, when we take a look at data after the Thanksgiving potentially predictive surge, that we can look at CVC5 as another option for ICU care. So there are already teams that are working on getting CVC5 ready if we need to use those bed spaces for ICU or moderate care. These micro adjustments, as David had said, are really important for our surgical volume. I know he has been meeting regularly with the chairs to talk about how we can move things off the hill into some of our regional sites so that we have additional bed capacity for patients within the footprint of UH and CVC. These managing transfers according to established principles has been so effective, and I give our teams a great deal of credit. Being able to take patients into our health system that need the care throughout the state is really important to us, but also to ensure that we have the ECMO therapies or the renal replacement therapies that people need in the machines, as well as the staffing and the bed capacity to manage those patients would not be possible if it wasn't coordinated through a daily communication at multiple levels. We continue partnering with our general care, moderate care units, our ICU care, as well as clinical services to optimize capacity. And much of that happens at an 8:15 huddle with bed ABCC, bed management, our super AOD, our clinical directors, and our ICUs and moderate cares to take a look at the current state, patients in the beds, and where we need to move them to in order to continue amazing throughput. That would not be possible without also our care management team. They have done an amazing job moving patients out safely, either to home or other levels of care. And in addition, using our ambulatory care footprint to offer alternatives to hospitalization through some of the therapies that have come about with COVID care. If you could go to the next slide, please. So we learned a lot as we went through the first surge of the pandemic, and opening the RICU, as Dr. Miller had alluded to, is really disturbing to teams. We also know that as we do these micro adjustments, even though it's not sending people to the RICU, our nursing staff, our providers, including our APRNs and PAs, they have to learn potentially a new skill set if we move them. So the team-based approach, by leaving teams intact to the best of our ability, are the guiding principles that we're working off of, because we know we get used to working with the people on our team, and it gives us a sense of security knowing who we can count on. We also know that the emotional impact and stress of floating staff off a unit to take care of a population of patients that aren't their home unit causes additional burden and stress, and it makes people, maybe potentially, not enjoy work as much that day. So we want to continue to provide a good work environment. Every time we add a different skill mix onto the units, we know that we need to make sure our staff is competent to do that work. And they have to learn that in a short time frame. So once again, these are all stressors, and we're trying to reduce as much stress as we can, but really avoid opening the RICU, which is, to be honest with you, a much bigger stressor. Using our HRO principles, it's important also to know who to escalate an issue to. And if we move people around, our HRO principles of reporting safety concerns, as well as who to report to, becomes problematic when we are unfamiliar with leaders that are maybe not as familiar with versus if you're on your home unit. We have confidence that we learned a lot of lessons as we open the RICU, and that we'll use that information successfully to apply these lessons if we do have to open the RICU, and what the impact will be to staffing as we move through this. If I could have the next slide, please. So David started with employee safety and emotional well-being, and patient safety as well as employee safety is my biggest march, I guess I would have to say. It's a key priority as we move through the surge. We know that historically throughout the country, PPE has been an issue, and I'm very proud to say that PPE has never been an issue here. We have adequate PPE. We have done an amazing job with the contract to get N95s through a new company called Haylard, and they have actually a 3-year commitment to provide us with as many N95s as we need. We continue to look at those figures, as well as ways in which we can ensure that it is an adequate supply. We heard many nurses say that they wanted to see the transparency in a dashboard, and we have now a dashboard where any employee can look online and figure out days on hand and what we have as far as PPE to move through the pandemic. Adequate staffing has always been a concern when you go through these types of surges. Last time we had to disrupt our staffing plan significantly, going to a pandemic staffing model. That is not the intent. By leaving people on their home base, we've been able to adequately supply staffing for all areas within the hospital. But we were very proactive early on to secure ICU staffing through agency. And to be honest with you, we probably have the most agency staffing to help support our ICU teams if we have a surge in the future. That would impact our ICUs in a greater capacity than it does today. One of the other things we heard loud and clear was that asymptomatic testing was requested by our employees, and starting mid-month, we will be doing asymptomatic COVID testing in Towsley. I want to reinforce the support of mental health. I always end with this, is that we are here to help people through the burden of going through another pandemic, another surge of this pandemic, and we face some challenges ahead of us. But I know that we have a bunch of people in our well-being office that are amazing and really want to work with us to help us get through this. And so I want you to reach out if you do need them. The last slide is just information for you to refer back to. If you could advance the slide, please. And I'm not going to spend a lot of time on this, because Kelsey's going to give us some more information on how you can reach out to their resources that they have through the Wellbeing Office. So the next speaker we have is Dr. Sandro Cinti. I'd like to just leave this message by saying I am eternally grateful for the work that you do every day to provide the finest care for our patients. I'm amazed at the work that's happened and the coordination of services between all disciplines. And I am so proud of our teams and what they've been able to accomplish with these micro adjustments. It just goes to show you, when we work together, we can accomplish great things. And so thank you, each and every one of you, for your service and dedication. Next, we have Sandro up to talk about COVID-19 vaccines and therapeutics.
I'm here. Can you hear me? I can't find my face.
We can hear you.
Okay, there I am. Okay, thank you. I'm gonna update. Thank you, Nancy, very much. And I'm gonna update on what we're doing in the Vaccine and Therapeutics Task Force. And I do also want to acknowledge all the work. If we go to the next slide, many of you have seen this before, but this is the huge effort that's going on. And I want to acknowledge again my co-chairs, Dana Habers and Stan Kent, and also Carrie Wright, who is doing the project management and really keeping us on task and scheduling hundreds and hundreds of meetings, it feels like. So this work keeps going on. And as Nancy was saying, people are overworked and overstressed, and we are asking them to do even more with this committee work. We added to this, you might see down here on the right lower part of this slide, the university team, and I'll talk a little bit about how that is expanded. The scope of this has ballooned a bit, and it will get into also how we might improve staffing of vaccinator clinics in the future. Let's go to the next slide. This is also, these are subject matter experts, and they are crucial, and we're asking them to go to as many meetings as we're going to right now. So thank you for all the help there too. Again, these are people who are already doing their day jobs, and we're asking them to do even more. Let's move forward. These are the two vaccines, still the same ones, Pfizer, that Pfizer started in the UK a few days, or they will be starting next week. As everybody saw, it was able to achieve an EUA for the UK. I don't know if it's an EUA in the UK, but they were the Pfizer vaccine will be starting in that part of the world. Moderna is not far behind. We will probably be starting to vaccinate on December 15th. We're going to have less doses than we thought we would, and I'll discuss that a little bit in upcoming slides. The Moderna vaccine's about a week behind, and if everything goes as it should, which is the safety data that we're looking at, the efficacy data is up here, and I think I've showed this before, is very good for both, 95% at preventing disease. But we're still waiting for the safety data. The preliminary safety data is very good, but we're waiting on the data from the 40,000 or so from the Pfizer study and the 30,000 or so from the Moderna study that have gotten 2 doses. So very important for us to see that. And that will be happening next week when the FDA's advisory committee, Arnold Monto is one of our public health folks here who's on that committee, and I think he runs that committee. And then the ACIP is the Advisory Committee on Immunization Practices, is going to meet right after that in order to make recommendations. So let's go to the next slide. The vaccine prioritization groups has changed a little bit. We showed another slide where group phase 1A did not include long-term care facilities, but those groups have now been included in addition to healthcare personnel. So we are really going to start phase 1A on the 15th, and that is healthcare personnel. Long-term care facilities, we have some association with those facilities, certainly, but those will be taken care of by CVS and Walgreens, amazingly. Those pharmacies will go out to long-term care facilities and vaccinate residents and staff. Phase 1B is what has caused our mission to balloon. Phase 1B includes essential workers, and those include the education sector. And that, by the way, is the campus of the University of Michigan. And so we've been asked to expand our efforts. So as we elide into phase 1B from phase 1A, that we're ready to help vaccinate those folks. So we've been starting to have a lot of discussions on the university side. And as a matter of fact, Dana, Stan, and myself just gave an update to President Schlissel about the work that's been done. Phase 1C will be the adults greater than 65 and those with high-risk medical conditions. And then phase 2 and 3 will come after that, and we'll start to subsume the rest of the population. The hope is that we can try and get through phase 1A and 1B within 4 to 6 months. But we don't know, depending on how much vaccine we get, we'll see if that's possible. What we're hearing is that vaccine supplies are shorter than what we thought they would be initially. We were initially going to get 300,000 doses in the state of Michigan, and that appears to be lower to about 80,000 doses. So that'll affect how much we get at the University of Michigan too. Let's move on. Those will increase pretty quickly though. The phase 1A planning scenario is that we have 30,000 employees, and we we want to vaccinate those folks first in phase 1A. This will also include people at the university who are in the School of Pharmacy, Nursing, Medicine, and Social Work. Kinesiology is in there too. So there are people in the phase 1A that we have to bring into our vaccination process from the university also. We will have limited doses initially, and what we're hearing is we may in the first week have as little as 975 doses, and those would go to our age greater than 65-year-old healthcare personnel. We've done some of the numbers, and it looks like we have about 1,000 people who are over or equal to over the age of 65, and so we will put out a message to get those folks scheduled and vaccinated. The following group will be high-risk conditions, and I won't go through all of these, but those are pretty well characterized at the CDC, and we will follow those. And then soon after that, as vaccine ramps up, we'll get others started and scheduled. This is going to take a while, and I would really, I really want to say be patient, because this is going to be tough. There'll be people who think they need to get vaccinated who might not be able to get in right away. There are folks who think that it should be done by section of the hospital versus just doing having a big pool of our healthcare personnel. We're working on all that right now, but we are trying, and we will follow CDC guidelines and ACIP guidelines. Let's move forward. This is the phased activity, and we thought in the beginning, maybe we were a little naive, but we thought, oh gosh, phase 1, we'll do phase 1 and then we'll go to phase 2. But no, there's a really elision here, I guess would be the word, where phase 1 goes into phase 2. Phase 1A goes into phase 1B. And you can see by that we're going to be doing the Hill as well as ambulatory care. We're right now looking at to potentially 1 or 2 sites on the Hill, 1 or 2 sites in ambulatory care to be ready to go on December 15th. And then as we move forward within the next weeks after that, then phase 1B will start. So we will not have finished phase 1A before we get into phase 1B, and that will include the university. And so there is a big effort, and you'll see in the next few slides how we're going to manage that. Let's move forward. So essential workers in phase 1B include educational sector. And if you look at the definition in the CDC, educational sector includes K through 12 and higher education. So that means we need to vaccinate our professors as well as everybody around them who is helping with the mission of education at the University of Michigan. And that probably, if you take the University of Michigan Hospital, all our employees and the University of Michigan, that's going to be up to about 60,000, maybe up to 80,000 people that we're going to need to vaccinate. Not just once, that's twice, so double that. It's about 160,000, maybe more doses that we'll have to give over a period of time. So again, be patient and you will get your vaccine. Let's move forward. We are developing what's going on right now is one thing that we've asked people to do is do extra work around their jobs. What we realized is that the job of coordinating vaccinators really needs to be managed by 1 or 2 people and with a staff behind them. And so we are now looking at a COVID vaccination central coordinating office. As we ramp up, we would like to create this office where there will be an operational lead from Michigan Medicine and from the University of Michigan, leading an effort to identify vaccinators, to coordinate training of vaccinators, to coordinate scheduling at different vaccine sites, and to manage all the business functions that go with that. So that is being developed. It won't be ready before we start the need for vaccinating in phase 1A, but that's okay because we've been moving forward to phase 1A. And this is really to the later parts of phase 1A into 1B that we will really start to need this coordination effort and this coordination office. Let's go to the next slide. And these are our partners around the area. St. Joe's, MDHHS, Washtenaw County Health Department, IHA, the VA. We are also need to acknowledge that we are, of course, the university itself we're working with. We have to realize that we don't want to appear as if we're just vaccinating ourselves and our academic colleagues at the University of Michigan. And so we really want to work with the community and as much as possible be able to help out where there are problems and deficits. And the Washtenaw County Health Department has been doing a great job, but they are understaffed also. And so as much as we can help with that effort, we want to be there and do that. And I think everybody feels that way. Next slide. Just to go through the therapeutics effort, we have a great team, including Tejo Gandhi, Lindsay Petty, Jared Nagel, and we have Anna Klemke, and they are working on the therapeutics, monoclonal antibody. As you may remember, or if you don't, these are IV therapies that are given in the outpatient setting. So we've had to develop a center where IV therapy can be given, where people have to be there for an hour for the infusion and an hour to be watched afterwards. The group also managed to be able to give this during the Thanksgiving holiday. So what a great effort. And this group is really working hard. They've given 40 doses of the monoclonal antibody. I think that's probably more than anywhere in the state. And we're getting more doses, and we'll be able to do more with that. If there are two products right now, Eli Lilly and Regeneron. Let's move to the next slide. These are the prioritization groups right now. You have to be positive for COVID. You have to be an outpatient. These drugs work best in very early disease. They work to drive the viral load down and to prevent people from being placed into the hospital. So we're really focusing on those early infected patients. As you know, testing can sometimes be difficult. So it's not as if somebody comes in sick, gets a test, and then goes right to get this. The test can take 1 to 2 days to come back positive. So it's a big structure around looking at tests, identifying the people who have positive tests, identifying those further who fit for getting this drug, and then calling those people and saying, do you want this drug? What that means is that you as a clinician can't ask for this yet. You can't just call and say, oh, I have a patient, I need to get this patient in for monoclonal antibody today. This is centralized process right now. There's a lot of work going on to expand this. We want to be able to give this on a larger scale. We want to be able to give it equitably. So we're right now, it's at West Ann Arbor. There are efforts and people who don't live close to West Ann Arbor. We're developing a transportation system so that they can get there. We are also going to work with home infusion to try and find a way to get the home infusions done if possible. We're not quite there yet, but discussions continue. Okay, I think that's all I have. I'm not sure, I came in late. Oh, Brian Zink, okay.
Hi, I'm Anselm, and thank you to you and your team for all your great work. You are definitely the light at the end of the long tunnel here, so we really appreciate it. So thanks. So on behalf of Senior Associate Dean for Education, Joe Kolars, and Associate Dean for Medical Student Education, Raj Mangrulkar, I wanted to briefly discuss the importance of our educational mission in this challenging period as we have another COVID surge. This ties into Dr. Desmond's email that went out yesterday. So we have an awesome academic health system, and education is an essential part of who we are. Given that, we consider our learners to be essential members of our healthcare teams, and we expect them to be active contributors to patient care. And just as we've adapted how we meet patient needs clinically, we're continually adapting how we educate our students in the clinical settings. You may recall that last March, with the first COVID surge, medical students were pulled out of their clinical rotations. They were thankfully reinstated this summer, and things are different now, and that we're better able to manage COVID patients while we're also serving the great majority of our patients who are not afflicted with COVID and need us for other medical issues, as Dave and Nancy were talking about. Now, I remember being a learner and trainee as the HIV and AIDS epidemic surged in the 1980s, and being able to actively participate in the healthcare teams and to care for patients with AIDS was incredibly meaningful for me as a learner. And I still remember specific patients from that time that I helped care for. So I don't need to tell you that we're really busy right now. We're happy to have our learners back, including our medical students back on our teams, and we want them to be in the mix. We also want everyone to be as safe as possible. So if you go to the next slide, we'll just provide some suggestions and guidance on that. Next slide, please. So here are some safety guidelines for you to consider for our learners and patient care settings. They fall into 3 categories listed here. First, we suggest that teams doing in-person visits or rounds should be limited to 1 provider and 2 learners. For example, maybe a faculty member, a resident, and a student. You might consider assigning learners to a subset of patients in order to allow for smaller teams. But each clinical situation is going to be different. These are not rules, they are suggestions, guidelines for you to think about. The second category, the middle one here, has to do with being innovative in order to meet the educational goals. For each visit and each situation, you want to consider the educational needs. For example, if you need to demonstrate an exam finding, there's going to be a need for direct patient contact. But if you're observing a learner's interview skills, that may not require patient contact and could be done with appropriate distancing. We're all getting more comfortable with technology these days, so we encourage you to use it as a way to include learners in patient care. We know this is already happening. For instance, bringing a medical student in via FaceTime or Zoom into a clinic visit from outside the room could be done. And also, we encourage you to include learners in the virtual care visits whenever possible. And the final category here just has to do with being aware of your environment and PPE usage. As a reminder, when it's possible, there should be 6-foot distancing between workstations and in team rooms. Where I work in the emergency department, this is harder to do, but we're still trying to distance and always masking appropriately per policy and allowing space and distance when people are doing nutrition breaks, again, not to be close together if they are eating or drinking. And finally, hand sanitizer, disinfectant, use it all the time, readily available in your clinical settings. So if you have any questions about infection prevention as you're bringing learners into your situations, so please call the number there or email. And just in closing, I'd say education is a big part of what makes Michigan Medicine so special. We would ask that you do everything you can to help our learners use their energy and their talents. They're amazing individuals, make them active and engaged members of our teams. And if you have any questions about educating our medical students in a clinical environment, please reach out to Dr. Raj Mangrulkar or Dr. Joe Kolars, who are eager to help you work through any issues that come up. Thanks very much. And I'm going to turn over now to Kelsey Stratton.
Thank you for inviting me today. I'd like to start by acknowledging the incredible stress and uncertainty and worry that so many are feeling right now. More than anything, perhaps, is a feeling of exhaustion. And what I want to share is that, of course, these feelings are normal and expected given this challenging time. And so my hope for today is to share some information and resources to ease the weight of this stress, even if just a bit. A question that I'm often asked in my work role is, how do people know when they need additional support? And what I might say to that is, if you're thinking about reaching out for help or resources, please do it. Of course, I understand that it's also difficult to seek help, given the busy demands of work and personal life. And it can be difficult to ask for help when you're the one used to providing the assistance. So if nothing else, the message I want to share today is this, that each one of us would benefit from having more supports in our lives. It's okay to ask for and to accept help when needed. The kind of support that you need may change over time. Right now, I know that many of you are feeling so very tired. Tiredness comes when we struggle to meet our essential needs, the needs for safety, predictability, connection, and purpose. Tiredness comes from grief and loss, from worry and anger and sadness. But there are ways to replenish energy and to reduce fatigue. We can do that by reflecting on and caring for our essential needs as best as we can, and by sharing the weight of this crisis with the people around us. This is a time to be there for each other and to reconnect to the purpose that sustains you. Next slide, please. I want to share a model that can be helpful for reflecting on psychological needs and supports, especially during times of stress. This model provides some common language for how many people experience stressful events. And so it starts with the foundation that we all have mental health, and people move back and forth on this continuum of health. Personal reactions to increased stress also fall in a continuum. In a time of stress or change, you may feel little to no impact, or you may feel a more significant impact. And in this model, mental health can be thought of as existing along this continuum of thriving to surviving to struggling or crisis. And when stress is ongoing or severe, this can lead to burnout or traumatic responses. At a time of widespread crisis, like we are living in now, perhaps no one is in the green thriving zone. And again, that's normal and expected. Personal experiences, support systems, coping strategies, and the length of time that we felt that increased stress can contribute to where we fall in the continuum of stress responses. It's also important to know that people will react differently to the same situation, and that's okay. Expect that where you are in this continuum can and will change depending on the level of stress or resources in your life. You might be okay and not okay in the course of a week, a day, or even an hour. I share this with you because you can use this model as a reflection tool to check in on your stress level and changes in mood or energy on a daily or weekly basis, and to seek resources that you might need. Sometimes you'll be able to cope on your own and drawing from your own strengths and skills and resources. There will be other times when you will need more help. So please know that what you are feeling and experiencing matters. It's likely that many other people are experiencing similar feelings and that there are resources and people to help. This stress continuum may also help you identify distress in the people around you. If you notice that someone, a colleague, a friend, a family member, is showing some signs of distress, you can check in with them with compassion and curiosity. We can share the weight of the stress with our community. That includes peer support and the kindness and care of our colleagues. Recognizing and responding to distress requires vulnerability and courage. It's not easy to do. The goal of sharing our pain and struggle is not necessarily to fix the problem, but rather to make the weight of the experience more bearable. We need each other. Next slide, please. For those of you who would like to learn a little bit more about your mental health needs and options, I'll share a few resources. There are several no-cost anonymous screening tools that can help you identify signs of depression, anxiety, insomnia, and many other concerns. The Michigan Medicine Depression Center and mHealthy have several self-assessment tools on their websites. These tools are not diagnostic, but they can help you understand the severity of your concerns and direct you to available resources for further assessment. Next slide, please. The Office of Counseling and Workplace Resilience supports the mental health of Michigan Medicine faculty, staff, retirees, and benefits eligible adult dependents. Our services are compassionate, completely confidential, and offered at no cost. The office provides individual and couples counseling, as well as crisis support, group sessions, educational offerings, and consultation with leaders on mental health topics. We also serve as an information and referral resource. You can contact us at any time with questions. We want to make it easy for you to find help. The Office of Counseling and Workplace Resilience coordinates the COVID-19 Stress Resource Team, which is a multidisciplinary team of mental health professionals who provide in-person and remote crisis support to healthcare teams and individuals. If you've had a tough day or just want some guidance or have questions, we invite you to contact us for confidential, brief support using a psychological first aid model. To contact the Office of Counseling and Workplace Resilience, you can call 734-763-5409 or email at counseling@med.umich.edu. And you can also use that contact information to access the Stress Resource Team. And of course, you may also use your health benefits to access mental health treatment, and many mental health providers are offering telehealth, and telehealth is covered under the health plans. Next slide, please. I'll also remind you of a few additional resources and websites. So the Michigan Medicine Wellness Office website is a comprehensive source for emotional health and well-being topics. and the site coordinates with the many partners providing emotional health services. Our Department of Psychiatry has expertise in many of the issues impacting faculty, staff, and their families. And so the department created a toolkit called Michigan Psychiatry Resources for COVID-19. It has a wealth of information on specific mental health conditions, as well as resources for children and adolescents, adults, and tools for healthcare providers. The Michigan Medicine Depression Center has an online toolkit that includes mental health screening, education, and resources for anyone seeking help for themselves or others. And many of you may be familiar with the mHealthy programs, which offer a wide variety of resources for all aspects of well-being. Next slide. Finally, I want to acknowledge that we're nearing the end of the year, and this will be a time when many will be celebrating holidays or reflecting on the past 12 months. This winter season will look and feel different. Some of you have experienced immense losses this year, and so there will be grief. Some of you have experienced frustration, anger, anxiety, and worry. Others may be looking to 2021 with some hope. There's no easy one-size-fits-all solution to coping through a crisis, but a few things can help in a moment of difficulty. We need opportunities to pause, to rest. We can use brief moments of time and space to identify the help we need, as well as the help we can give. In the space between tasks, how can you pause to reflect and to move forward with a renewed sense of presence and purpose? Refocus on what you can do with the goal to simply improve the moment with a greater sense of peacefulness. Consider which routines are comforting to you after a stressful day. Routines can also provide a much needed sense of predictability during uncertain times. Be gentle with yourself and with others. Look for opportunities to build community and connection. How do you share your love and care for the people and causes that matter most to you? Seek additional support from family, friends, colleagues, or mental health professionals. Together, we can recognize our common humanity, share the burden of suffering, and move forward with compassion and with hope. Thank you.
Thank you, Kelsey. And with that, we're at the Q&A portion of the town hall. Let's see, we have just a handful of minutes. We had many questions again today. So as always, we will do our very best to answer any questions that we don't address today in the week's coming communications, email communications. Let me start with a quick question for Dr. Zink. Brian, if you're still available and can come back on, that'd be great.
I am here.
Super, good to see you. Brian, a question we had was, give me 1 second to get back to the top here. If cases continue to increase, how will our various residencies be affected, and how will we ensure that educational needs are met?
Yeah, so I think I probably need to defer that over to Dave. But I think in this model, the need for moving people around or to different areas of different workplaces or different units should be reduced. And as Nancy was saying, so I'm hopeful that the impact on resident learners would be less than what we experienced the first time around with the first surge. But I don't know if David has any additional insights on that.
David, if you want to come on, or if not.
Yeah, I think Brian answered it correctly, and I think working with Sybil, I think that we've tried to avoid redeploying of residents so that they can get adequate training. And the balancing of both COVID and non-COVID enables us to continue the educational programs in a much stronger way to meet their educational objectives. So I think any redeployment directly for COVID will probably be faculty only or other teams. So.
David, do you want to stay on? And I've got a couple just going to we have many questions this week, so I'm going to just give you two kind of sort of policy related questions. One is, with the very significant rise in COVID, why are we still asked to perform completely elective, including cosmetic procedures? What is the rationale for not postponing these procedures?
Well, I think every day they're looking at, I would just defer the operational team. Every day we're looking at what I would call it, not necessarily elective, but scheduled essential services. And we still are having to reschedule 3 or 4 patients every day, but it is challenging. I'm not sure that we're doing a lot of plastic other than maybe for educational reasons, but I think most of what we're already scaling back a lot of our scheduled activity, at least 3 or 4 cases Wednesday, Thursday, and Friday, and we'll have to create another 10 beds next week. So it may be a further reduction, but it is hard to do. We are talking about people who have had neck cancer and other types of surgery that are being delayed, and we're trying to figure out how to continue both COVID and non-COVID.
Thank you. And then just one other question for you. Big philosophical question. How does our leadership envision our hospital's role in the regional COVID response? Do we have a moral obligation to increase our ICU capacity to shoulder more of the regional COVID cases, given our excellent clinical outcomes?
Yeah, I think that this gets to the issue of what are we uniquely qualified to care for. So last night we had a patient transferred who had neurosurgical condition as well as severe Crohn's disease and required both surgical ICU care. That is a patient that couldn't be cared for anywhere else. So we do have, we have expertise to take care of patients who have ARDS and specifically ECMO, but we also have expertise to take care of patients with certain certain surgical diseases. And so we are trying to balance that. And I think we do have an obligation to try and provide those services for which we are uniquely qualified to take care of, but that is not just COVID, but also non-COVID care. And the deaths that occurred in the spring, or the excess mortality, 1/3 or more than 40% were due to non-COVID disease and delays related to that. And so we have to balance both. And I agree we have an obligation as a state institution to meet this challenge. But it is not one disease. It is a series, it's a lot of conditions and diseases that we have to try and balance.
Thanks, Dave, very much. So at this point, we're going to run out of time before we can really get through any more questions. I just want to give people a sense there are many, many questions about vaccines, both policy as well as many more questions about the rollout. I think we'll need a proper dedicated FAQ to address those. There are questions around benefits again and what will happen to benefits if we continue to have research, questions about whether executive compensation cuts have been restored and whether the at-risk payments for executives will be paid out. And there are then many questions about again, how we're going to be handling the surge and the micro adjustments on a go-forward basis. So we will do our very best to answer all of these questions in the days ahead. And we'll see if we can reserve more time at the next town hall for more Q&A time. With that, I want to close out the town hall with this video. If the slides can advance to the video, that'd be great.
This journey has been long, and it hasn't been easy. But now is not the time to let your guard down, because grandparents still need you. Teachers need you. Nurses need you, and their babies still need you. Traditions need you. Your communities need you. Wear a mask. Maintain social distance. Be safe. You're ready for this to be over? We are too. And how we get there is by doing the right thing. Now, together.
Thank you. And the last slide, our next town hall will be on December 18th at 2 p.m. and we look forward to joining you all then. In the meantime, be safe and thank you all again for all of your hard work and dedication during these challenging times.